Well, thank you again so much for having me here tonight, and I'm excited to share this information. One of the reasons that I was reached out to is hearing that I run our women's bleeding and clotting disorders program at Brigham. I'm dealing with this topic all the time, and so knowing that we can't get to everybody's individual story, I wanted to start by talking about kind of classic examples of what might show up in clinic dealing with this difficult issue of heavy menstrual bleeding or heavy periods in the setting of being on blood thinners. And so I want to give two examples of the kind of thing that a lot of people may be experiencing to ground us as we move forward. First is a 43-year-old woman who was recently diagnosed with an abnormal heart rhythm called atrial fibrillation and a stroke as the way it was diagnosed in a complication of that heart rhythm. She was asked then to start warfarin, which I'm going to try not to use brand names for a lot of reasons here, but since folks are more familiar, I'll have them up as well. So the brand name of that is Coumadin, to prevent further strokes. Obviously, the stroke itself is super difficult in this scenario, but trying to return to a sense of normalcy after recovering from that hospital stay has been really difficult because her periods are so heavy that she has to leave work meetings abruptly in order to change a pad or risk bleeding through her clothes in public. So this has been really intrusive for her moving forward. Another example is a 28-year-old woman. She had a blood clot in her lungs called a pulmonary embolism after being started on birth control pills, which were started because she already had heavy periods. She starts on a blood thinner to treat that pulmonary embolism, rivaroxaban, brand name being Xarelto, and stops the birth control pills because they were thought to be part of the cause of her blood clot. Now, she was already dealing with heavy periods before even starting blood thinners and is very worried that they're going to get even heavier. She is now avoiding going out with friends or any activity where she might not have continuous bathroom access. So some of these scenarios might sound resonant to people and others might be a little bit different than what you've been going through yourself. But I want to kind of keeping these ideas in mind of what I'm taking care of all the time. I want to set our agenda of our education before we dive into individual questions. So we're going to move through and use some definitions. I always say when I'm teaching our med students and residents and all levels of people learning to be doctors, that nobody got taught in their middle school health class what a heavy period is. So we shouldn't assume that our patients know, let alone our colleagues, unfortunately. So I'm working on that on the education side, but for all of us, we want to start there. We'll go over some reasons to be on blood thinners because it helps us understand a little bit what some of our choices might be moving forward to deal with the bleeding, impacts of blood thinners on the rates of bleeding, some of the consequences of heavy periods, as well as the lab tests that should be going on to monitor, and then some strategies, some actual action items, as well as what you can bring back to your doctor, since of course I can't talk to you about your individual case. So I want to make sure everybody leaves feeling a little bit more comfortable knowing how to use their time at their doctor's visits. So as mentioned, what is a heavy period? So you might hear a lot of us when we're in medical speak saying menses or menstrual period, but that I'm probably going to say period the rest of the time because that's what we usually say when we're outside of a medical visit. Heavy has several different definitions, and you don't have to hit all of them to be there. But classically, since I don't expect anyone here to have learned this officially, we say anything longer than 7 days. Anytime your pad, tampon, or whatever else you're using for your period can't last for at least 2 hours. Passing a clot bigger than a quarter. And then not everywhere uses these definitions, but some sources will also talk about things like a gushing sensation, like you can feel the blood flowing, or bleeding through clothes or things that indicate that you have difficulty controlling the blood flow. With these different considerations, what I would say is, well, this is the official definition of what a heavy period is that we use in research and other quantification. If your period's intruding on your life, it's too heavy. And so I don't ever use this as a way to tell people to just deal with what they're going through. It's not officially heavy, but this can also really help people understand, because since periods are not part of normal dinner table conversation in our culture, a lot of folks just don't really have a sense of where they sit on the spectrum and might not realize that what they've been dealing with is actually very heavy. So in terms of blood thinner uses, I'm assuming most of the folks joining in tonight themselves have had to be on blood thinners at some point as the premise of why we're here. So I don't want to go overboard on the medical lingo in the background, but I do just want to orient us to the fact that there are sort of 2 different flavors of being on blood thinners. Those who are on what we call a treatment dose or a full dose, and those who are on a prevention dose. Treatment doses are used to treat things like a recent blood clot, the original blood clot itself. Examples of that are pulmonary embolism or PE and deep vein thrombosis or DVT. As I already mentioned in one of the vignettes, abnormal heart rhythms, particularly an abnormal heart rhythm called atrial fibrillation that can make clots form in the heart and then cause strokes as they break off and move around the body, is another indication to be on a treatment dose. And then mechanical heart valves, which since I'm a hematologist, I do not take care of those very often. But those are all reasons to be on a full or treatment dose. In contrast, and one of the things that's really important to keep in mind when we think about some of the strategies we can use moving forward, there are other reasons to be on blood thinners, but be at a prevention dose, which is usually substantially lower, depending on which blood thinner. Some are in the ballpark are half or even less than half the dose. And the idea here is that protection from blood clots in some of these scenarios might be able to be accomplished with less than it takes to treat a blood clot that's there. So with that, there are certain scenarios where we think about protection. It might be somebody who's had a history of a prior blood clots, and so they've done their treatment course, but now to prevent something in the future, we're down to a lower dose. That might be continuously used, or it might just be used intermittently when there's a specific extra risk happening for a brief period of time. Additionally, there are times where somebody might have a lot of extra risk factors for blood clots, especially strong family history, and there are certain scenarios where we might use prevention for that purpose. And then there are other scenarios where we use prevention doses of blood thinners for everyone. As a great example, if you have a knee or a hip replacement surgery, that's really high risk for anyone, no matter their history of blood clots, and so you might be on a prevention dose in that context. And so not all of this applies for everybody listening, but I think it's really important to realize that there's two really different ways to be on blood thinners in terms of the intensity. When we think about the impact, though, for anybody who is dealing with heavy periods on blood thinners, you are the norm. It's not that you should deal with it, but approximately 70% of people getting their period who are on a blood thinner have officially heavy periods. And so that is by far the majority. And so you're not in it alone, even if your doctor hasn't stopped to talk to you about it, or even if you felt uncomfortable bringing it up. But the other thing to keep in mind in terms of the blood thinners is that not every blood thinner has the same rate of heavy periods. And so we know that sometimes switching around between them is one of the things I'll talk a little bit more about in order to help you. Specifically, as hematologists, we bucket these into two groups. It's not that any of them have no bleeding or no risk of extra bleeding, but there are ones that have more and less. So we talk about rivaroxaban and edoxaban, and here I just have the brand names for the second one that are both the US and Canada, in case anybody here is from north of the border. And those medications have actually been shown to have meaningfully higher rates of period-related bleeding and heavy periods than other blood thinners. And so again, it's not that these other blood thinners don't also increase the rates. It's just that warfarin, enoxaparin, which is an injection blood thinner, and apixaban, which is also called Eliquis, which is one of our most commonly used pills, have a lower rate among these. So we can keep those in mind for comparison. In terms of consequences of heavy periods, this audience probably doesn't need me to spell these all out, but I still want to make sure everybody realizes that what you're going through is not just you. First of all, the number of different medical articles that show the high rates of missed school and missed work are so many I couldn't cite them all if it was the only thing we wanted to talk about today. And I think those are common ideas. You can't get through your work meeting, you're doing an experiment in a lab, you're trying to drive without having to stop to use a bathroom, many other scenarios where normal time spans. But the other, and I alluded to this in one of our opening vignettes, is avoided socialization. I have lots of patients who just feel more worried than able to enjoy themselves if they're going to be in a scenario where they just don't know whether they're going to be able to control their period bleeding. And with that comes understandable anxiety about things like bathroom access and the embarrassment of bleeding through. I think there's a lot of cultural norms about how teenage girls in high school might have difficulty bleeding through, and kind of that being sort of one of these embarrassing coming of age stories. But that can put extra pressure and extra embarrassment when it's happening to adult women, as though the answer was that you didn't know what to do with your body or hadn't gotten used to being a woman. If you're having super heavy bleeding, this isn't about you not having an understanding of what to do. It's about the fact that the bleeding is really that heavy that it's hard to navigate. And I know that that level of embarrassment or anxiety or difficulty just with the mess can be really limiting. And these are all things that I think most people who are dealing with heavy periods don't really need me to point out, other than, again, to say that you're in a safe space tonight and we want to talk about all of this and strategies that you can use to think about it and make it better. But the other that often gets neglected is that losing all this blood means losing iron. Every time red blood cells leave your body, they take iron with it. And so having heavy periods is the single most common way to get to being iron deficient, especially in countries like the US and Canada, where we have the ability to have iron-rich diets, but even around the world. And so with that, whether or not you're also anemic, that's another big consequence of heavy periods that gets under addressed and can be adding to your symptom burden and reducing your quality of life. What is important about iron deficiency is that we always think about it in two buckets of symptoms. We have symptoms related to anemia when your iron is so low that you can't make enough red blood cells, but there are also some symptoms I'll come back to in a moment that really are actually about the iron itself, even if you're not anemic. So common symptoms of anemia, whether it's from iron or otherwise, include fatigue, shortness of breath, and decreased exercise tolerance. That last one is our medical term, but you can think about it as the idea if you're a runner, maybe you can't run as many miles, but it can also manifest in other ways in your life. Like you used to have no problem walking 8 blocks, carrying your groceries back to your home. And now that's just not doable. And you're having a hard time with those routines of daily living in a way that's really limiting. And so with that, we also want to think about some of the symptoms of iron deficiency that aren't just from anemia, because sometimes doctors do a bad job about catching the iron deficiency if people haven't gotten all the way to being anemic, but that's actually a late manifestation of iron deficiency, and brushing off symptoms from iron deficiency just because someone isn't anemic is not appropriate. So with non-anemic iron deficiency, meaning your red blood cell number is still normal. We usually measure that through hemoglobin, but you have a low iron. You can have fatigue separate from the anemia, but other symptoms that can be really troubling, like hair loss, restless leg syndrome, which can keep people from sleeping well at night, further adding to how exhausted you feel. A very common symptom of iron deficiency is a craving to chew on ice or clay. And so somebody in the audience may have had that experience themselves, as when the iron is okay. It's not really an interest, and other times it's something that is a habit that people get even teased about sometimes by friends or family. And the last, it doesn't apply to anyone where I'm living because I'm in Massachusetts, but people are more prone to altitude sickness when iron is there. So just a few different reasons to be careful about this. So with that, there's some lab monitoring when you're on blood thinners that's important for everyone. And then we'll talk about some things that are not true for every single person on blood thinners, but really important for everyone here today to keep in mind. It's typical with any blood thinner, if you're on it, to be getting your blood counts checked every 6 to 12 months. With this, we're looking for anemia. I think I just heavy-handedly explained why we're worried about that on the slide before. And also checking your platelet count, another part of your blood that's important for forming blood clots and making sure you're not at extra risk of bleeding as a complication. And then since some of these medications are cleared out of the body by the kidney, keeping an eye on kidney function. And so that's an expectation of part of your care. With heavy periods, though, something that often gets neglected, and part of why I want everyone here to feel empowered to advocate for themselves, is directly checking that iron. I won't torture everyone with the details of how hematologists keep track of iron, but it's really important actually to learn the name of this other test, ferritin, because that's actually the warehouse for your body to keep iron and more accurate than the iron number itself. And so these are things that if you have heavy periods, should be part of every time you're getting, well, not every single time you're getting your blood counts might be excessive, but a couple of times a year, this should be checked on if you're continuing to have heavy periods. And sometimes it needs to be more frequent than that if it's been a recurrent issue for you. I won't go too far into it today, but for those people who are on warfarin as their blood thinner, INR or international normalized ratio tests are also important. That's how that blood thinner is managed. And for folks who are on it, they're probably very familiar, so I won't belabor that. So I've gone through a lot of background and a lot of things, but up till now, I'm sort of telling people some things they may already know. And we want to shift over to what you can do to help manage your periods. The first thing, and part of why we started with this idea that not all blood thinners are the same, including how much of a dose you're on, as well as the type, is that this may be an option. It may be an option for you to adjust your blood thinners if it's safe. Here's where it's really important to make the point that I'm not going to hear about anyone's individual medical history today, and you may have a condition or scenario in which it's not appropriate to use one of these strategies. But a lot of the time, the first step can be switching to one medication with less bleeding. So for example, switching from rivaroxaban to apixaban amongst the medications. Another might be if you're a person for whom it is safe and appropriate, dropping the dose level to prevention dosing instead of the full dosing, because this is something that we know has a lower rate of bleeding. Alternatively, if you're a person, again, for whom it's safe, One strategy I use a lot is to hold or reduce the dose just temporarily around the heaviest days of the period so that peak bleeding isn't occurring with blood thinner in your system. Again, I'm obviously very paranoid about accidentally giving anybody any bad advice, so I want to be really careful to say this doesn't apply to everybody, but all three of these strategies, and sometimes in combination, can make a huge difference if you're the right person. So just checking in with the person who does know your medical history, your hematologist or cardiologist may be able to answer for you if one or more of these things might help you deal with your heavy period. Additionally, in terms of contraception, I will pause and say that the term contraception in this context is always a little bit frustrating. We don't have a medical term for all the things that we use to reduce periods that act by also preventing pregnancy. So we're talking about contraception here, but most of the time the motivation is not to block pregnancy, but to control the periods. We're going to go over in a few moments contraception choices that have different clotting risks, and there are some that don't have any clotting risks that could be really helpful for your care if you're not already using it. Additionally, we want to address the iron deficiency. It's a side effect of being on blood thinners, but it's not a side effect you have to live with. We have really effective treatments. There are both pills and IV formulations of iron that are available in most places, and you should be able to get to it if you have persistent iron deficiency and can't tolerate pills or they're not working. And I'll come back to that in a moment. Additionally, I hope today is part of you finding the right emotional support, because whether it's because we can't get all the way there in terms of medical conditions really requiring you to stay on blood thinners, or having that only partially controlled periods, or just being exhausted from all the medical visits you have to go to get this sorted, really hope that you understand that this is hard. And just because as a society we don't want to talk a lot about periods doesn't mean that you should have to feel alone in coping with it. So I hope this is one of many things that you can use to find that good emotional support in order to get through dealing with this. So I mentioned that contraception and clot risk is not the same across all different types of contraception. I'll mention here there are two buckets of contraception that don't have extra clot risk: a copper intrauterine device, or IUD, which for this discussion I should flag specifically is known to actually increase bleeding while being extremely effective at preventing pregnancy. So it's absolutely true that it doesn't have an extra clot risk, and it's totally fine if you want to use it in terms of preventing pregnancies. It is not going to help you if your motivation is heavy periods. It's actually going to do the opposite. Part of the reason why I have it here is also to mention that if you yourself have a copper IUD and have heavy periods, switching to a different type of IUD is one of the things that you can consider as an intervention, because sometimes people don't realize that there are other options that are safe, even if you have an extra risk of clotting or have had a clot yourself. Most progesterone-based methods, and I'll explain what those are because I know not everybody's going to know what that means, are safe. Specifically, the other type of IUD, this thing that gets inserted into the uterus to prevent pregnancies, are safe. We know that from lots and lots of data. So the levonorgestrel is the generic name, but most people will know them by their brand names, which are Mirena and Kyleena, are the main ones in the US. And these are something that can be placed in the uterus, outpatient, very low risk. Experienced gynecologists can place it without stopping blood thinners, and then they can last for years. Progesterone-only pills are an alternative that are also very effective prevention when used correctly. But of course, you have to be taking a daily pill, which if you already have a large pill burden, maybe that's not something appealing to you. And then the autonogestrel implant, and I will tell you medically, almost no one calls it that because it's a bit of a tongue twister, but people who are familiar with it will know it as the Nexplanon, the implant that goes in your arm. So those are all different forms of contraception that are clearly shown to reduce periods. Some of them even stop periods altogether, and are completely and totally safe to use with a prior clotting risk. On the other side, things to avoid and things to be careful about include estrogen-containing contraception. So this is the classic pill, the standard thing that most people are aware of. This one definitely increases the risk of blood clots in all the different formulations, including the low estrogen ones. And if you have a history of blood clots, it's usually not appropriate. Having said that, there are some special scenarios where people who really, really need to be on an estrogen-containing medication can talk to their doctors about how to find ways to minimize that risk and keep you safe. The other thing I want to point out, and I put special emphasis on this because this is an area I know a lot of other doctors are actually unfamiliar with, There's one form of progesterone birth control that actually is clearly associated with a higher risk of blood clots. And that's the shot, the Depo-Provera shot, as the brand name of progesterone, is clearly associated. We actually don't 100% understand why that's the case, but it's been clearly shown across studies. And I think it probably is just because it's so much higher than the amount of progesterone that's normally in the body. In a lot of other scenarios, this is an excellent form of contraception or control of periods. But if you have a personal history of blood clots, this is an important thing to be aware of. Again, because this is often not something a lot of doctors and other healthcare providers are aware of. They sometimes mistakenly lump it with the other forms of progesterone-based birth control. So that is a hematologist take on contraception. There's lots of other things to learn about that topic, but just approaching it when you're thinking about what might be an option. So in terms of things to share with your doctor, before they can give you good advice, they have to know things. And I really wish that every doctor taking care of someone on blood thinners would just ask all these questions and not have patients have to offer them. But I just know that's not the case. And sometimes that's because people just don't feel comfortable. We should, but with that, here are things you really want to let your doctor know. Tell them about your periods. Hopefully they'll bring it up, but if they don't, you should. Tell them if your cycles are regular or not. That helps us with things like the idea of, I can't ask someone to reduce their dose for the first 2 days of their period if we have no idea when that's coming. So cycles regular or not help us think a lot about what different approaches we can take. And then help them answer those questions that I said define heavy menstrual bleeding. Tell them the number of days you bleed for, how frequently you have to change a pad, tampon, or whatever you're using, and if you're passing clots bigger than a quarter. Also share with them how this affects you. This is not necessarily something you're going to be able to talk about on end, just because we know doctors' visits can be really crammed. But let them know if you're having symptoms that you think might be related to iron deficiency to help them remember to check. Let them know if you've been started on iron pills, if you aren't able to take them. These are really helpful for dealing with iron deficiency, but they're notorious for causing nausea, acid reflux, and especially constipation. So lots of people get prescribed them and then can't take them. And you should just share that with your doctor. With iron pills, nobody's going to be especially surprised that you're not able to deal with them. And that's a great time to pause and think about other ways to get iron into your body. And then also let them know about pregnancy or contraceptive needs. I just went through a whole long list of the different contraceptives and how some of them might help you and some of them not. If you're trying to get pregnant, it's obviously pretty darn tone deaf of me to tell a patient to get an IUD in that's meant to prevent pregnancy for several years. And if you aren't sexually active, that might change what you want to do. Or if you're, worried about getting pregnant, there might be an urgency. And so just do your best as you can to share those things. There's also things to ask your doctor. And this is when I want to pause and point out that doctors are not all the same in terms of what they're expected to deal with you. So I think probably most of the people on this call have met a hematologist or a cardiologist that's managing their blood thinner. But there are things to ask your doctor about. Are you a person who might be appropriate to drop down to a prevention instead of a treatment dose? Is it appropriate for you to, in the context of your own medical care, be on less intense blood thinners during periods? Or could you switch between the different blood thinners to one that has a slightly lower rate of bleeding to see if that's really impactful for you? Also, ask them directly if they've checked for iron deficiency. Maybe they've been so focused on your blood clot, they forgot to step back. And if it's done politely, I never take offense to my patients bringing up something that I wanted to get to later in the visit or at another visit if it's important. And you can also ask them if you're having difficulty with iron pills or very, very anemic, if you might be able to get iron by IV. I know not everybody's coming from large medical centers or might be in different circumstances, but this is something we do routinely for many of our patients at the Brigham and Dana-Farber. And so this is accessible to a lot of folks, and including that's the case in most hematology offices do a lot of iron infusion to get connected. There are also some questions that I would say, while your hematologist or cardiologist might have an opinion, they're going to need to pull in a collaborator. Specifically, while I clearly spent a lot of time thinking about different contraception, I don't place IUDs and nor do the cardiologists. And so if something like that or a progesterone implant is something you're interested in, you're going to need to have a primary care or gynecology team that is able to offer that for you. And they may also be additionally able to help you and usually are the ones doing prescriptions for other forms of pills. The other thing to keep in mind is if your periods were heavy even before blood thinners started, make sure someone stepped back and thought about why. If they've been heavy lifelong, maybe that's just the bad luck of your genetics. Maybe there's time to pause and think about other reasons to be prone to bleeding. But oftentimes, if periods have been escalating, especially as you are aging, there might be things the gynecologist needs to look for, things like endometriosis, fibroids. I can also talk to you about perimenopause. Perimenopause is one of those other topics that we don't talk about very much as a society. And I think if you watched a movie or something as your only way of learning about it, you'd probably think that people just gracefully have their periods peter out and stop bleeding. But in reality, it's extremely common for periods to get heavier approaching menopause as cycles become more irregular and hormones fluctuate more. And so there are different strategies that we can think about depending on the cause, especially if there is something like a fibroid, which is something in the uterus can, like a area in the uterus that can bleed more readily, that there are other approaches other than thinking about it just from the hematology perspective. And so just want to make sure that people don't anchor so much on blaming the blood thinner that they forget to step back and think about other things that might be adding. A couple of things, because as I mentioned, we really want to make sure we don't accidentally imply bad medical advice, is that there's some things that you absolutely should not do without talking to your doctor. Even if you think you fit exactly the person I've described that might be appropriate to stop or decrease or pause your blood thinner, talk to your doctor about it beforehand so we don't have something scary happen. Some people, for a variety of reasons, are asked to take aspirin alongside a blood thinner, and sometimes that's medically necessary, but it's associated with more bleeding risk. NSAIDs are the group of medication folks sometimes know that term and sometimes don't. So examples are things like Advil, Motrin, which the generic is as ibuprofen, naproxen, which is also the same thing as Aleve. So that's another class of medications that carry some bleeding risk. Some people, it is okay to combine small amounts, but that's something you should really talk to your doctor about with your medical history. The last is starting supplements. It's not that I have an issue with vitamins or over-the-counter supplements in general, but there are some supplements that have interactions with blood thinners. For example, turmeric is really popular right now, and there are certainly some benefits to being on it, but it also interacts directly with some of our blood thinners, and as a result can meaningfully increase bleeding risk. And so if you're thinking about starting a supplement, it's not that you can't necessarily, but I would imagine that there are many people listening who had no idea that the levels of turmeric that are used in supplements, not usually in cuisine, but not in food, but there might interfere with their blood thinners. And so just keeping those things in mind. Having said that, I know that I just dumped a lot of information on everybody. And as a person who does a lot of education, both with patients and with our medical students, I know that this is a lot to absorb at once. Just keep in mind that if you need to hear things more than once or want to get into more depth, there's a lot of different resources available.